You're sitting on the toilet right now, or you were 10 minutes ago, and you felt it. That fullness, that pressure, the absolute certainty that something is right there and simply will not come out. You shifted, you pushed, you waited. Here is the thing nobody has pointed out to you about that moment. The harder you pushed, the more your body may have been locking the gate shut. In the next few minutes, I am going to explain why stool gets stuck, what your muscles are actually doing in that moment, and a clear, step-by-step path to fix it. If you have ever left the bathroom feeling frustrated and a little bit scared, wondering if something is genuinely wrong, you are exactly who I make these videos for. Here on Doctor's Plain English, I take the topics that are hard to talk about and explain them like a friend. No judgment, just the truth. Subscribe so the next one finds you. I am Dr. Hannah Fields, and difficulty emptying the rectum is one of the most common clinical patterns I see, and one of the most misunderstood. A 2020 review in Gastroenterology Clinics of North America found chronic constipation affects roughly 15% of U.S. adults. Among those, many have outlet dysfunction. The problem isn't how fast stool moves through the colon, it is the exit itself failing. Most people just hear, "eat more fiber," and when that doesn't work, they feel broken. What if the problem isn't what is going in, but what is happening at the very end of the line? Think of your rectum as the end of a water slide with a gate. That gate is your pelvic floor, muscles that hold everything in until you're ready. Normally, you sit down, the gate relaxes, the angle straightens, and stool passes. But two things go wrong. First, coordination. You push, and the gate clenches tighter instead of opening. That is called dyssynergic defecation, muscles doing the opposite of what they should. A 2019 study in the American Journal of Gastroenterology found nearly 40% of patients referred for constipation had this exact pattern. Second, hardening. Stool sits too long, loses moisture, and forms a dense mass, an impaction, too firm to pass. Sometimes both happen together. When a solid mass blocks the exit, liquid waste higher up can seep around it and leak out. This looks like diarrhea, but reaching for anti-diarrheal medication here is a mistake. It slows your system further, cementing the blockage. If you see liquid alongside days of feeling full, call your doctor first. This is called overflow. Finally, because your rectum and bladder are neighbors, a hardened mass can press forward, causing sudden urgency or difficulty urinating. Your bladder isn't the problem, it's just being squeezed from behind. I think of a patient I will call Nora. She was healthy and active, but every bowel movement felt incomplete. She would strain for 20 minutes, face red, and still feel full afterward. Psyllium and prune juice did nothing. Nora told me she felt like she had forgotten how to do something her body should know instinctively. Her muscles weren't broken, they were just confused. Here is what matters most, and I am going to walk you through it in order. Straining harder often makes things worse. Bearing down triggers the exit muscles to clamp shut in people with coordination issues. It also risks hemorrhoids and blood pressure spikes. Tonight, instead of holding your breath, exhale slowly and let your belly expand outward. This helps the pelvic floor release. Your position changes the geometry. Sitting upright keeps a muscle called the puborectalis tightened, creating a bend in the path. Elevating your feet and leaning forward relaxes that muscle. A 2019 study in the Journal of Clinical Gastroenterology confirmed this reduces straining and improves emptying. If stool is hardened, follow a patient protocol. If you do not have a history of inflammatory bowel disease or recent rectal surgery, you can try a glycerin suppository. Lie on your left side, use lubricant, and wait 30 minutes. If that fails, walk for 15 minutes, then try a warm saline enema. If these thorough attempts fail, go to urgent care. A clinical team can resolve this safely and provide immediate relief. Ask for specific testing if this recurs. Anorectal manometry measures your coordination. Biofeedback therapy, retraining those muscles, is highly effective. A 2021 review in Diseases of the Colon and Rectum confirmed its success. Nora did 6 sessions and finally felt her body work in harmony again. Before I give you your action plan, I want to ask you something. Did you know that liquid leaking can actually be a sign of a blockage rather than diarrhea? Tell me in the comments if that surprises you, because I think it catches most people completely off guard. Here is how to remember everything we just covered. Think of it as clear the gate. Change your position with a footstool. Let go of the strain with a slow exhale. Escalate to suppositories or an enema with patience. Ask for manometry if it keeps happening. Recognize overflow before treating it as diarrhea. Tonight, find a stool to lift your knees above your hips. Practice the exhale technique. If you haven't emptied in 3 days, call your doctor. Avoid daily stimulant laxatives. They can train your colon to become dependent, making it harder to go naturally over time. Watch for blood, severe pain, or difficulty urinating. Those need same-day care. Straining triggers the gate to close, so exhale instead. Position changes the angle, so elevate your feet. If stool is hardened, use the protocol with patience. Recognize overflow correctly. And if it is a pattern, ask for testing. Nora doesn't spend 20 minutes in the bathroom anymore. She is back to her life. Thank you for staying with me. You are not just a set of symptoms. You are a person whose body is trying to find its rhythm again. Share this with someone who might be struggling in silence. Subscribe to Doctor's Plain English. Tonight, try that footstool and 1 slow exhale. Come back and tell me how it felt. Everything I have shared today is for general informational purposes, based on real research and clinical patterns I see often. It isn't a diagnosis, and it isn't a substitute for your own doctor, who knows your specific history. Please check with your physician before making any changes to your medications, diet, or health routine.